Good evening, everybody. I am Dr. Arun, and I come from Kottarakara, and this is my first time at IMA Kuttalam, and I'm very happy to be here. So I would just like to add to what my previous speaker told about. You must have noticed that the previous speaker spoke about double markers and quadruple markers and NIPT. So I would like to say that we at Vijaya Diagnostic Center, we will be able to give you the results within 24 hours for both the double markers and the quadruple markers, and including the NIPT. Okay, so now before I start my presentation, you must have noticed that the topic, okay, it is mentioned that trust but verify. So what is this? What does this mean? Trust but verify, what does it mean? So before I go into my presentation, I would like to conduct a very small quiz competition. If you are interested, we'll just go forward with it. So can any of you tell me who this person is? Anybody, can you please tell me who this person is? Anybody recognizes this individual on the screen? Yes, it is Ronald Reagan. He was the President of the United States during the Cold War era. Okay, that is exactly right, madam. And who is this person? Mikhail Gorbachev, the last president of the USSR. Okay, so he's the last president of the USSR. So why I showed this is because there was a very famous Russian saying which goes by doverai no proverai. Translated into English, it means trust but verify. So that is what we do at our lab. So what basically we do is we give you reports, we expect you to trust in it, but always make sure that you verify the results. So the reason why I am telling you this is because during the Cold War era, before the USSR was broken down, Mikhail Gorbachev said that he has committed to denuclearization, but Ronald Reagan said, yes, I believe you, but I want to see. I want to see that that process has taken place. So that is the same thing that we do in our lab. We will tell you why it is and how it is. So I'll move forward with my presentation where I'll show you two cases and what are the differences and how it happened. So normally what happens is lab reports, they give you a lot of different meanings, but often what happens is lab reports are overlooked. So I'll give you an example of how these lab reports are overlooked. So first I have got a case. The case is like this. A 28-year-old man presented to the emergency department with severe abdominal pain. So he had a history of binge drinking on 3 days prior, and he has got abdominal pain, nausea and vomiting. So once this patient has been presented to the hospital, what happens is we send the lab reports, okay, we send the blood for investigation. And as a preliminary diagnostic, you already know that it mostly could be pancreatitis. So we want to know what is going to happen to the patient. So this is the lab report that has been given. Okay, so in the lab report, you can see that hemoglobin is 21.2, hematocrit is 48%, hemoglobin is increased, MCHC is 44.2. So mean corpuscular hemoglobin, a value of 44.2 is physiologically impossible. Okay, it is physiologically impossible. The ceiling for MCHC is around 38 milligrams per deciliter, 38 grams per deciliter. Beyond that, normally it is not possible. Only it happens in the case of spirocytosis. Okay, then we have got a sodium of 122, amylase 92 and triglyceride 1877. So here you must have noticed that the triglycerides are increased but the amylase is very low. So here it is actually a patient with pancreatitis and vomiting. The amylase should have been increased, but here it is not increased. So now how do we proceed with this case? That is what we need to see. Now another thing about the sample that has been received in the lab is the sample is milky or turbid in appearance. Okay, so here what we see is, we have seen that the sodium is around 122, that is dangerously low hyponatremia, and that requires urgent medical attention. But is that report reliable or not? That is what we need to see, okay, if that report is reliable or not. So here what has happened is, we have got a patient with a clinical picture of acute pancreatitis. He's got hypertriglyceridemia. What happens is, all these triglycerides, when it increases, it will go and block the arteries supplying the pancreas, thereby blocking the pancreas, leading to inflammation. That is how we have got pancreatitis, and the rest of the things have been followed. So these lab reports, should we believe these lab reports or not? So that is where the communication between the lab and the clinician comes into play. Okay, so when we get such a report, if it does not fit into your clinical picture, make sure that you will be able to call the lab and talk to a professional who knows what is happening. So now, this is what I meant by a milky sample. You can see on both sides, one is a clear sample, the other one is what is called a milky sample or a turbid sample. So here the problem is the lipemia. The increased lipemia and the turbidity has affected the reading. How it has affected? It is a long story, but briefly if I tell you, it will be about, it interferes with that mechanism that we use over there, and that mechanism is called spectrophotometry. So that mechanism has been interfered with, and therefore amylase, which should have been increased, we have got it as a normal value. It should have been increased, it has been, this procedure, the turbidity has interfered with that value. Similarly, sodium also you should have seen, sodium was dangerously low, it is 122 milliequivalents per liter. Here it is not a true hyponatremia, but a pseudo hyponatremia, and that has been caused due to what we call volume displacement, which will interfere with a method that we use in the laboratory, and that is called ion sensitive electrode. Basically, sodium reading will decrease. So that is where you need to correlate. So if I go by each of those reports, if you want to verify each of those reports, the first one, hemoglobin, you will see that it is 21.2 grams per deciliter. This is dangerously, falsely high. Here what has happened is, this is not the true value, but the lipemic sample has caused the hemoglobin to increase. It is a false value. Similarly, hematocrit. Hematocrit has increased. It may be true, it may not be true. The patient has presented with vomiting, so it may or may not fit the clinical picture. The mean corpuscular hemoglobin, it is impossible. As I told you earlier, mean corpuscular hemoglobin, the ceiling is 38 grams per deciliter. It can increase only in cases of spherocytosis. But this is not such a case. So this alone will tell you that this lab result is not reliable. And then sodium, as I told you earlier, it is low, and amylase, it is falsely normal. It should have increased, but triglycerides have interfered with the value. So what I am trying to tell you over here is, the lab reports might not fit with your clinical picture. In that scenario, what you can do is call the laboratory and speak to a professional so that they will be able to help you diagnose what is happening at that moment. Okay, so as I told you, communication with the laboratory and communication with a professional is very important. That is why we at VDC, we have got professionals dedicated to laboratory work. Now, one more patient, this is my last case. One more patient I'll present to you. It is a 72-year-old male. He is a patient with a known case of metastatic prostate cancer. But now, this patient has responded to treatment, but there is worsening of bone pain. So, I'm sure that all of your clinical knowledge will tell you that this treatment is not effective because the bone pain has worsened. The patient is going into more and more meds. That we know. But once you send the blood to the laboratory, the result that you get looks something like this. So here you can see the total PSA value is 4.2, which is almost normal. Alkaline phosphatase has increased. Yes, in case of bone meds, it can be increased. Then we have got hemoglobin, which is decreased, and creatinine, which is slightly increased. So you know that it is a case of metastatic prostate cancer, bone pain is worsening, and yet the PSA value is almost normal. So now, is it okay or is it not? That is what we need to know. So what do we do in the lab? How do we analyze it? What is the problem here? That is what I am trying to tell you. So here we have got what is called a high dose hook effect. So that is true for all hormones, same like PSA. So here what happens is, we estimate it using a method called ELISA. So in ELISA, as you know, it is enzyme linked immunosorbent assay. So in enzyme linked immunosorbent assay, what happens is, we have got antibodies which are called capture antibodies, and they are supposed to capture the prostate specific antigen. But here, because the amount of PSA is too high, we will not get a true value. Most of the PSA will not be captured by that, and that is what is called a high dose hook effect. In this scenario, what we should ideally do in the lab is the sample should be diluted and then it should be estimated so that we get a true value. So this is just an example to show you that. So this is what I told you. So in this procedure called ELISA, we will have, when there is extremely high antigen concentration, the antibodies will not be able to capture those antigens, and therefore the sandwich formation fails, and therefore we will get a falsely low result. Okay, so my take-home message is, when you see a laboratory picture and if it does not fit with your clinical picture, the most important thing that you can do is either communicate with the laboratory, or even better is, whenever you send a sample to the laboratory for investigation, if possible, write a very brief clinical history. Okay, at least what are you expecting? What did this patient come with? So that we can correlate with our results, and if required, we can come back to you and we can ask you what is happening over there. So in relation to that, why is VDC different? Why is our Vijaya Diagnostic Center, why is it different from other laboratories? So I'll just give you a brief example. Most of the laboratories, what they do is, they have got what is called a marketed quality, where they will show you they have got NABL accreditation, they have got barcode readers, they have got all forms and all that. But that is not actually what matters. What matters is we need trained technicians and trained professionals, trained doctors who understand what is happening. So on that note, I would also like to add that we are an NABL accredited laboratory. We just got our NABL accreditation 2 weeks back. So we are into the field, and our center is basically based in Kottarakara, which is around 1.5 hours from here. And we have got currently 2 centers running here at Surundai and Chengota. So now I will just come to one more point, and with that I will finish. Competence versus qualification. Can any of you tell me what is competence and what is qualification? How do we differentiate between competence and qualification? So there is a very interesting story, or a very interesting way in which I would like to tell about competence and qualification. So I will take the example of a driving license. Okay, I am sure that all of you here, most of you at least, will have a driving license. Most of you will have a driving license. So just because you have a driving license, that means you are qualified to drive the vehicle. But are you competent to drive the vehicle? What is the difference? If you have a license, you are qualified to drive, but competence means that you will be able to drive the vehicle safely, take it from your home, cause no harm to anybody, and bring it back to your house. That is competence. Okay, so that is the difference. So just because having a license does not mean that you're good enough. Competence is what actually matters. Okay, so in any laboratory, if you give a blood sample, they can simply feed it into a machine and they can give you results, but those results need to be verified. Those results, you have to understand what is happening with the patient. Okay, so once again, so at Vijaya Diagnostic Center, we are a very well-established lab, especially in Kerala. Now we have got 2 centers in Tamil Nadu, as I told you. Okay, so we started as a very small hospital way back in 1998, and now we have grown and we have got different centers. As you can see, we have expanded. We have got College of Nursing, we have got College of Management, okay, and we have developed. And we have got 2 centers here at Surundai and Shenkotai. We are going to improve. We have got different centers at Shankaran Kovil, Ambasamudra, Tengashai. Okay, we are going to improve. And moreover, we have got different routes also, collecting samples from all of these places. And most importantly, we have got trained professionals and trained doctors to look into the result, and those who are able to interpret the result and give you a real diagnosis of what is happening. So thank you all for that patient listening, and thank you for listening to me.